Assalamu alaikum and good evening, dear participants. Respected physicians, today is our 97th session of ECG study group presentation, ECG Basic and Beyond. And today is the case-based discussion. And today's presenter is none other than Professor Gobinda Kanti. Gobinda sir. And before the lecture starts, I'd like to request Rafique Ahmed sir to introduce our today's speaker, and then we proceed for the further lecture. Rafique Ahmed sir.
Thank you. Sorry, I'm in London. My video is not working for some reason. So, this is a continuation of our lecture series. I know Gobinda very well, and he is well known in our group, plus all over Bangladesh. He is Associate Professor of Cardiology and Chief of Cardiology at Mymensingh Medical College. He's keeping that place very active, and I hope we'll have a very good, enjoyable lecture today. Gobinda, please proceed.
Thank you, sir. Honorable founder course directors and international course directors, and Dr. Rafique Ahmed sir, one of them, and our Dr. Chowdhury Ahsan sir also, and moderator, and dignitaries, faculties, and learned audience. Today, I'd like to talk about 3 cases. Next. And it's my immense pleasure to be here, present my case in front of giant mentor or mentor professor. It's my really immense pleasure. So before going to main slide, all of you know legend scientist William Anthropian, which invented ECG 1895 and got Nobel Prize in 1924. And this case number 1, a 65-year-old male diabetic smoker having chest pain for 4 hours and shortness of breath, palpitation, and history of syncope and pulse, bradycardia 40 per minute regular, and blood pressure too much low, 85/60 millimeter of mercury, and jugular venous pressure raised, and cannon wave seen, and lungs clear. And this is the ECG. This is the first ECG. And if possible, any poll and any comments from audience voluntarily or dictated by any our chairperson or our sir.
You want poll, Govinda?
Yes, sir. I also knock Mr. Kamal from Beximco for putting just putting poll.
But sir, what is the option, sir?
A, B, C, D.
আমি বলে দিচ্ছি স্যার, অপশনটা ওইভাবে হচ্ছে না। অপশন কমপ্লিট হার্ট ব্লক, number 1 complete heart block, number 2 complete heart block with first degree AV block, number 3 left bundle branch block. At first complete heart block, B, A complete heart block, B left bundle branch block with first degree AV block, C left bundle branch block. 18টা only 3 with ST elevated MI in inferior and old MI anterior in all the cases. But the reason
option
is the problem.
3, তাই তো? That is complete heart block, left bundle branch block with first degree AV block, and হচ্ছে
only left bundle branch block.
Only left bundle branch block. These 3 are the options.
Yes, sir. And all options along with the inferior MI, acute ST elevated inferior MI with old MI anterior.
Govinda 100% মানে option A.
Option A.
Actually 10 candidates participated. Nice number.
Excellent. Close করে দাও এটা. Excellent. Complete heart block. It's a typical rate around the 40, and there is a AB dissociation, complete AB dissociation, and white QRS complex, and ST elevation significant 2-3 ABF, and also pathological QA and C1, C2, C3, C4, and RR interval regular. If you see the rhythm stiff and PP interval regular and PR variable. Next. Now, after rush into the our coronary care unit, we give oxygen due to saturation 89%, antiplatelets loading dose with enoxaparin and PP, that means pethidine phenergon, fluid challenge, diuretics, and insulin, as because patient has got diabetes mellitus as well. And this is the Canon wave. More. They usually complete heart block a regular Canon wave, and but in case of ventricular tachycardia, irregular Canon wave, and sometimes junctional tachycardia causes the Canon wave. And other investigation, blood sugar is 18 millimole per liter, serum creatine in marginally raised, serum electrolytes hyponatremic, and troponin I raised, antiprobumin so high. And bedside echo shows there is a anteroseptal, infraseptal, and part of the inferior wall, basal part of the inferior wall, also to some extent posterior hypokinetic, just only sparing the lateral part. And ejection fraction around eyeballing estimation 35 to 40, not more than 40. And there is a tricuspid regurgitation and mitral regurgitation as well. And the next ECG, also it's with a right-sided ECG. That means the RB infection shows the ST elevation, the C3, C4, along with the lead 3 and AVF. And ST depression 1 AVL looks like a dead man sign. Also, so complete heart block, acute ST elevated MI with RV infection, with LVF. In spite of having no rails or crepitation, we may label it as LVF. If we consider the Philip class 1, or you consider that according to American College of Cardiology, American Heart Association, structural heart disease symptomatic. So now plan for primary PCI with support of TPM, as because before that we give the other fluid challenge, but patient goes downgoing, not respond accordingly, so that patient is convinced for primary PCI with support of temporary pacemaker. And this is the angiogram, right system, complete block with TPM guided with canalization and putting the stent. And this is the after stenting, there is a open up the vessel. And this is the after CSG or angioplasty, this is the ECG. And this ECG shows what will be the, this is the left bundle branch block pattern or interventricular conduction delay, or with first degree AV block, or 2:1 AV block with LVB pattern. What will be the, if any, discussion, opinion? LV, previous LV, first time echo LV is a bit dilated. And the ECG shows the old MI antiseptal patient did not give any history of admission in cardiology department.
Gobinda, what was the presenting symptom of this patient? That is a syncope or chest pain?
Yes, syncope, chest pain, at first chest pain, shortness of breath, and syncope, fall down. And history of trauma also here in our emergency department.
So what is the time delay between your presentation and doing the primary PCI?
Around 145 minutes. 145, 150, as because the patient confused, or patient is about there is a disagree at first for PCI, primary PCI, as because the history of trauma to the brain in the brain, and also history of parectal bleeding. Previous his attendance, his son give history the parectal bleeding 2 days or 3 days day 4, so that we cannot try lytics. And as before the after fluid challenge, even inotropic support, patient blood pressure not raises and restlessness is increasing, so that we plan for PCI.
And this is after the procedure, na? What is the?
Yes, sir. Another ECG is this is the first ECG after procedure. Second, this is the second last ECG. Yet now prolonged PR interval LBB pattern. Am I right, sir?
Right.
Sorry, sir. PR interval to within normal limits.
PR interval with
PR
if you
interval.
see the
If you look into the
borderline.
V2, you can easily say it is within 20 millisecond.
Yes. V2, V3, but
200 millisecond. So it is no PR interval not prolonged.
Yes.
LBB pattern is there.
LBB pattern is there. Exactly.
Right.
Rafique, sir, exactly. Any discussion? If any discussion regarding this ECG or procedure management.
Gobinda, so did you do primary PCI in Mymensingh?
Ji, sir. It's not the
That's
first time. If previous another 5 or 6 cases during daytime, office time.
Fantastic.
Sir. Can we go second case, sir? Or any?
So, Govindu.
Move on second case or? Sir.
Govindu, as because this case, that is did this patient does not have any hypotension, cardiogenic shock like this, as you mentioned that the patient had got the RV infarction?
Yes, sir. Exactly. There is a RV infection and there is a hypotension and JBB raised, and there is a cannon wave also, and also tricuspid regurgitation. And after fluid challenge, patient BP was not responding or raised, even after inotropic support as well.
Excellent job. So you can proceed to the second case, Govindu.
Yeah. Thank you, sir. Move on, sir. Case number 2. A 65-year male has got chest discomfort, vertigo, disease spell, and also drowsy, and blood pressure 100 over 60 mm mercury, and heart rate 45 per minute, and lungs clear. Next. And this is the ECG. Just to take this is the ECG. Either complete heart block or any other possibilities with long T wave, tall T wave in B5, B4, B6.
Electrolyte
hyperkalemic. Potassium is raised 6.72 and also hyponatremic 116 sodium. So that patient was drowsy. Next. So we give, according to guideline, 3% normal saline, Gobinda, and anti-ischemic therapy, and follow-up monitoring. Next. and this is the ECG. There is no regional wall motion. There is a kissing movement, inward movement from all sides. Due to bradycardia, complete heart block rate is so slow, around 40, 35 to 40. And also, most interesting here, see there is a still picture, there is a diastolic MR due to complete heart block. Next. And after after admission in 25th and just one day after 26th November, ECG was done, and yet now complete heart block. And next, and just 27th October, here ECG, can we tell or label as complete heart block or first degree heart block or 2:1, what will be the possibilities?
Should be complete heart block.
Sir,
Should be complete heart block.
as because, but here the peer interval is constant.
Right.
Peer interval constant. P
R interval
PR.
constant.
R
And-
interval also constant.
And
So is
Is it-
there any P wave here over the T wave? Is there any?
PF, definitely there is a PF.
Is it here maybe
It is-
P
it
wave
is
just
very
merges
much
with the
clear
T wave?
It is very much
C2.
very much
If you
clear
follow
in
lead
C2,
C2,
C3.
C2.
C2 and C3, it is very much clear there is P wave.
Here. Exactly, sir. This is the rhythm strip, sir. Next. Is there any discussion?
Yeah,
Previous
Govinda,
sir.
as the patient was, I think the hemodynamically unstable, your second case,
Yeah.
the
Hemodynamically not unstable due to electrolyte imbalance, patient a bit drowsy due to hyperkalemia and hyponatremia, severe hyponatremia. But not actually the patient is on a failure, but complete heart block rate is very slow. Blood pressure 100 over 70.
So,
What did you do with this patient?
Sir,
What did you do with this patient?
patient already admitted in our hospital, and patient is clinically well, clinically stable. And but what can we do next? This is the most likely degenerative cause seems to be. But your opinion, sir, please.
No, I mean, the question is, the first ECG was complete heart block. But interesting, patient had hyperkalemia, but if you look at the sinus rate, it's not very slow.
Yes, sir.
When I saw that, I thought that these are two independent things going on. Patient definitely has conduction system problem plus hyperkalemia. And if hyperkalemia caused bradycardia, what you will probably see that lack of P wave, because either P wave sinus rate becomes very slow or you just cannot see the P wave. But of course, at the end, when you have corrected everything, patient is still in 2-to-1 heart block, right?
Yes, sir.
And I mean, ideally, a patient like that is an adult 65-year-old with intermittent contracture should get a pacemaker.
Yes, sir. Can we move on?
Sir, before,
Yes.
sir, I have just
Tushar,
a
Tushar.
question to you. As there are many other participants here. What do you mean?
Can you back to
diastolic
your
MR?
second
With
case,
echo?
the first ECG, second case, first ECG?
Sir?
Your second case, first ECG.
Second case, first ECG. This is the first ECG.
The first ECG, the beginning is complete heart, but if you look last two QRS complex, the second from the last is early, and probably that's conducted, but definitely by any definition, this is high-grade AV block or intermittent complete heart block.
Sir, as you described earlier, I'm totally agree with you, sir. As because whether it is consistent with the level of the hyperkalemia just above 6 potassium level, with the preserved QRS morphology and QRS duration, whether this complete heart block is related to the hyperkalemia or something, as you described, sir, the underlying contraction
Yes,
system.
definitely. The first thing, that's what we'll think, but you expect the sinus rate to be slower. The sinus rate here is about over close to 130 or so. But the second proof is that when Gobinda showed the last ECG, when the electrolytes were normalized, patient still has conduction system disease, 2-to-1 heart block.
Last is after correction.
After
Patient is
correction.
clinically okay, but should we put under PPM?
Why?
Should we go for?
The question is temporary pacemaker. If you look at the current guidelines for temporary pacemaker, they have made it very strict that do it if it is absolutely necessary. This patient did not have syncope. Even when he was in intermittent complete heart block with such a horrible electrolyte, he was hemodynamically stable. So there is no need to put a temporary pacemaker in this person. The decision will be, he needs a permanent pacemaker, whether that can be done. Of course, it's not like any other place. It's the question of affordability of the patient and all kinds of things that you have to think about.
Exactly, sir. And after correction of electrolyte, hyperkalemia and complex also is a narrow, almost
Yes.
normal.
But it's 2-to-1 heart block.
2:1 heart block. Yes, one is conducted, another is non-conducted. 2:1 rhythm strip.
So, Govinda, actually, what is the reason for the electrolyte imbalance? That is the potassium 6 and sodium 115.
History of vomiting, but two episode of history of vomiting. But without vomiting, there may be another cause. SIAD, syndrome of inappropriate ADH secretion, is one of the common cause for hyponatremia. Possibilities.
Rafique sir, I have a question, sir. Dr. Shafiq sir.
Sure. Hello.
Asif sir, alhamdulillah, ভালো আছেন, sir.
Yeah.
Sir, I have a question. Whether it is 2:1 or complete heart block, if it is sinus, just double the RR wave, it could be complete
Yeah.
heart block even, sir.
Yeah. Gobinda, can you show me the next rhythm strip?
Yes, sir.
Yes, this one. If you look at it, it looks pretty clear. I mean, you have a long rhythm strip and there is
Yes,
2-to-1 conduction. Sometimes you can see minor variation in the PR interval, but this relationship is it's a long rhythm strip. If it was complete heart block, you would see more variation. And if you measure it, I'll give you the measurement. 1, 2, 3, 5. Yeah, if you look at the RR interval is same as 2P to P interval.
right,
So
sir.
that, yeah, but even then, even if it is not exactly same, because sometimes you can see the variation in little variation in the PR interval, even in 2-to-1 heart block, and that can make things a little tricky. The question is how much, but this is a very good long rhythm strip. The other one, if you challenge me, I will say, I will go for, can you go back?
Yes, sir, exactly.
Yeah, this one, I'll say 2-to-1, but if you say, are you 100% sure? I'll say, well, I'll give you the benefit of doubt because we don't have a long rhythm strip here, but the next one is pretty long.
Sir, regarding our postgraduate student, OSPI, there may be somebody give answer the 2:1 block, somebody give complete heart block. So if anybody put the answer 2:1 block or complete heart block, is there any mark reduction or is there any?
Okay, so mark reduction in America, we don't do any mark reduction except if your decision kills a patient. So let's say somebody has 2-to-1 heart block and the student says this is complete heart block. he's actually not killing a patient. However, if somebody has heart rate of 25 with complete heart block, he calls it a normal sinus rhythm. He will get -1 because he has killed a patient. So that's how we decide about this. The other part about exam question is, look at this ECG. Dr. Shafiq is a consultant. I'm a consultant cardiologist. We are talking whether it's 2-to-1 or complete heart block. We're debating it. In United States, when we set exams, we give it to 5 independent non-academic practicing cardiologists to answer that question. And if all of them give the answer correctly, then only we put it in exams. So we don't, in exams, we do not put controversial ECGs.
Controversial, ambiguous.
No.
Thank you, sir. Can we move on?
Sure.
Thank you, sir.
Thank you, sir. Yeah. Next. Case number 3, a 47 years old pleasant patient having chest pain and shortness of breath for 7 days and blood pressure 130/70 millimeter of mercury, pulse 60 per minute regular, and history of sudden death of his father 1 year back. And this is the ECG. Next. This is second ECG. This is the outside. This case is in my chamber, was in my chamber. This is the outside, and this is my chamber ECG. My question, without having history, just only patient age, 47 years, male, what will be the possibilities for our MD cardiology or diploma in cardiology student? Could it be acute coronary syndrome? Could it be chronic coronary syndrome or aortic stenosis or ASOCM, ACM, or long-standing uncontrolled hypertension, or all of them?
You want a poll ABCD?
We have too many choices. So,
Gobindo,
Sir,
ACS, CCS make one A. Then
aortic
A,
stenosis,
B. ACM,
ACM, ASOCM একসাথে করে দেওয়া যায়, স্যার, combinedly.
good.
Hypertrophic
Yeah, I think so.
cardiomyopathy.
First two will be 1. Second, aortic stenosis, hypertrophic, HOCM 1 choice, and hypertension. So we have 4 choices.
Yeah, 4 choice, sir. C, that means hypertrophic obstructive or non-obstructive cardiomyopathy. Yeah, now aortic stenosis.
But
Sir,
But if we combine the interesting, if we combine the results, A plus B more than the C, but by
Yes, sir.
democracy, C wins.
No, B is aortic stenosis. C was hypertrophic cardiomyopathy.
Yes.
Yeah.
So most are goes in favor of cardiomyopathy, hypertrophic cardiomyopathy. Next slide.
Well, I mean, so before we go to the next slide, I'm curious, why did the participants choose like that?
Yeah.
I mean, every time we give a question, we have to think about why the answer was like. So I'm sure people who answered acute coronary syndrome, they thought about the chest pain. My problem is with chest pain is that if somebody is having chest pain for 7 days, he should be dead by now. If it is acute coronary, any Dr. Shafiq or Atahar, any comment on that?
No, true, sir.
Right, sir.
Gobinda, can you show the presenting symptom again, please?
This is second ECG.
No, the symptoms.
Oh, symptom. Chest pain, shortness of breath for 7 days.
I mean, is it constant chest pain or on and off chest pain?
But before 7 days, the patient was totally asymptomatic.
Okay,
So
but
he's a banker.
What kind of chest pain was it? On and off chest pain?
The ischemic type of chest pain, on exertion, moderate exertion.
Exertional chest pain. Okay.
Yeah,
So
exertional chest pain, sir.
it's not a constant chest pain that for 7 days. It's just exertional chest pain.
No.
But
Okay.
sir, another part is that definitely the patient had got this long-standing symptoms, but suddenly for the last 7 days, possibly it has been increased in intensity and frequency, no?
Sure. Yeah. I mean,
It's
if it
fluctuating a bit.
Yeah, if it is exertional chest pain for 7 days, shortness of breath, of course, acute coronary syndrome or unstable angina is a consideration. But if somebody is having constant chest pain for 7 days, that's unlikely to be, especially in a young person like that. But the ECG, what is the ECG? Let's forget about the clinical diagnosis. What is the ECG diagnosis, Gobinda? Your comment on that ECG.
Sir, here not only T inversion in the chest lead and also not asymmetrical, seems to be symmetrical. And also along with the inferior lead, we just follow lead 2, 1, 2 and also AVL 2, 3, AVF, also T inversion. So ischemic cause, it's maybe due to demands, supply demand mismatch, type 2 MI. One of the possibilities, or one maybe the type 1 MI, type 1 MI or type 2 MI.
Sure.
But sir,
Sir,
but there is the atrial change, that is the for the degree of the that is the hypertrophy and the T wave inversion. The T wave, that is the P wave change in V1 is not. It should be more than that is expected. What we see, that is there should be dilatation of the atrium and there should be some negative V1, sir.
Yeah. So if you focus on the T wave, looks symmetric, but the question is, patient definitely looks like have a LVH and short PR interval. So
short PR interval, yes, sir.
Yes. So I mean, left ventricular hypertrophy is a consideration. So I mean, we cannot come to a blanket clinical diagnosis of, but we have to consider all those options. That first of all, chest pain. Now, of course, you can have the same presentation in a patient with aortic stenosis. Aortic stenosis patient can have chest pain. So I think these are all logical clinical choices, right?
Sir, may I add some, sir?
Yes, please.
Patient heart rate a bit higher rate.
Yes.
So maybe some sorts of anxiety that might increases the heart rate for the last 7 days, and that makes the patient unstable. And because of the hypertrophic cardiomyopathy, more is the heart rate, more is the obstruction, and symptoms could be like that of ischemic angina pain.
No question. Definitely. So this is an interesting ECG and interesting clinical scenario. If this patient was 65, 70-year-old, we would think differently. But this is a 47-year-old. And then there is a family history of sudden death. Father, we don't know how old was the father when he died.
Sir, one thing is that here the short PR interval, it's a notifiable, it's a markedly mentioned or intermittent pre-excitation, something like that.
Well, there is no pre-excitation, because pre-excited ECG, you will see a little bit of delta wave, but this is just short PR, unless somebody has any other comment. Because if you look at the...
Sir, short PR is one of the criteria for the LVH, sir. That is
short. Exactly. So anyway, what was the echo finding?
Gobinda, sir wanted to know what was the age of the father. That is when he died.
Around 60, 65.
Yeah.
Age,
so
father.
that becomes a problem then, because when we talk about sudden death, I always ask patient, how old was your father or the family member who died suddenly? When somebody becomes 65, there can be so many causes. Yes. Somebody can have an MI and die from that. When we talk about sudden death, we are trying to find out, was there any sudden death from hypertrophic cardiomyopathy or something like that. So below the age of 55, it makes it more important. Or the age of 65, it can be any of the causes, acute MI, hypertrophic cardiomyopathy, primary VF, all those things. Go ahead. Okay.
Next. This is the investigation, serum creatinine, HbA1c. This is the real picture here. Just I like to move. The hugely thickened interventricular septum, if we compare with the posterior, inferior posterior wall. Next. Next. In the Tico's method, M mode over the parasternal short axis view at the base of the papillary muscle level, interventricular septal thickness in diastole around 25 millimeter, and the posterior thickness 13 millimeter, and ejection fraction preserved around 60. Next. This we go for mitral inflow study to see the diastolic dysfunction. Here, E velocity 116 centimeter per second and E by A ratio 1.7. Next, TDI. Open. Yeah. But there is no obstruction in the LVOT level. And also SAM not present in M mode, over the M mode cursor, the mitral leaflet and also septum. Next. Play. E prime velocity. Next. E prime velocity 4.64 centimeter per second. That means as a normal value 7 centimeter or more, medial, and lateral 11 centimeter per second or more. And E by E prime medial, if you consider just only medial, 25. That means at least a grade 2 or 3 diastolic dysfunction. So treatment, antiplatelets, beta blocker, or statin, either here indicated or not, hydrostatin. It's a matter of question. Or other anti-ischemic therapy strategy. This is my question. This is a matter of discussion. Actually, it's a patient of chronic coronary syndrome or just only hypertrophic cardiomyopathy, non-obstructive. But interventricular septum is hugely thickened. But gradient is just only 10 millimeter of marker, LVOT gradient.
Sorry, I missed the part. How thick was the septum?
Yeah, this sir.
What was the septal thickness?
25
24 or 25, 24.8.
Oh, sure.
24.8, that means 25.
Okay.
Is there any Valsalva maneuver done?
No, sir.
During the echocardiogram, heart rate was normal. Probably it was less than 70, right?
Yes, 60 to 65.
So, 65 heart rate. So in that case, Valsalva maneuver could be an option to see
obstruction. LVOT
obstruction.
gradient. Yes. One of the most important.
I mean, this is a difficult patient because if this patient came without the family history of sudden death, now the sudden death becomes important because let's say if this echo showed concentric hypertrophy compatible with hypertension, we will probably ignore that sudden death. But now with this severely thickened wall, so that puts one factor into this consideration that this patient is he at higher risk of sudden death and what to do about it. And he's in the right age group for that.
Now, is there any, sir, Pardon me, sir. Is there any septal reduction therapy like drug, newer drug, mavacamten, can we give?
Yes, that will be dependent on. So we always do cardiac MRI for these patients to see if there is any late gadolinium enhancement.
Amyloidosis.
No, LGE.
Sir,
If there is any scarring.
Scarring,
if,
yeah. Late gadolinium enhancement.
Yes. So if
Yes,
there
sir.
is any scarring and familiarity of sudden death, that patient gets ICD. And then, of course, the mavacamten can be used for symptomatic benefit. Because
sir, if there is no gradient higher, then mavacamten indicated.
No, that's the problem part. The problem part
Right,
is
sir.
that how symptomatic is the person, because mavacamten is for symptom relief.
Right, sir.
And it's a tricky drug, but it should be used in with careful assessment of the patient. But the question would be the sudden death problem.
Yes, sir.
Yeah.
Sir, this patient has got the class 2A criteria, sir, for that is a sudden death risk marker. That is the
yes.
There's a two respectors. So that is the IBS, the thickness more than 24.
Yeah.
And the history of other sudden death.
Yeah. So the younger doctors who was listening to our conversation, you see, initially I said 65-year-old sudden death maybe not that important, but then I changed my mind after looking at the echo. So the whole point is that the medicine is dynamic, and you have to look at all the context. When Gobinda presented sudden death of the family member, the next question we asked is how old was the father when he died?
Around 60, 65.
Yeah, that's the thing. That then we said 66 maybe not the right age, but you have to understand that hypertrophic cardiomyopathy has a bimodal distribution. Some of them die younger, and then some die between 60 and something, that age group in the 60s. So in this patient, a defibrillator is a consideration.
So what will be the advice for this particular patient? The banker patient is banker. But
you have to say what Atahar said. Look, you fall into this category, you will be at higher risk, and ideally you should have a defibrillator put in, and that's up to the patient decision what to do. And the other question is the drug like mavacamten or septal reduction therapy. Those are like, of the septal reduction therapy, alcohol ablation has no mortality benefit. Myomectomy has mortality benefit, but there are not many surgeons who do it. Mavacamten is symptom relief, but nothing else beyond that.
Actin-myosin complex. Yeah. So that we now go for CMR or coronary anatomy, we have to see coronary anatomy and also CMR.
Well, the thing is that we always look at the coronary anatomy. If somebody comes with chest pain, even if they have hypertrophic cardiomyopathy, it's a good idea to look at the coronaries. Good cases. I mean, any more case, Gobinda, today?
No, sir. No, sir.
But this is very interesting.
Thank you, sir. Thank you very much.
I enjoyed your lecture because there are two reasons I enjoyed. First, good cases. Second, we are seeing cases from outside of Dhaka, which is important. I mean, I passionately feel that we need to expand interventional cardiology itself, and also catheterization intervention outside of Dhaka.
Yes, all the cases is personal case, sir.
Yes, and the cases, and this is another part that Gobinda, you presented the cases which are your cases. And I would encourage everybody to present this kind of cases. Listen, you don't have to be perfect. I'm from the time of Bangladesh when only thing we had is one ECG machine in the hospital, and that was locked up in the closet, and it would be brought out at 10 o'clock in the morning every day to do some ECGs. And to see this Bangladesh is I always feel proud about it. And I would like all of you to bring cases, discuss cases, and expand cardiology outside of Dhaka so that the whole Bangladesh benefit from this knowledge growth. We have our limitations, technical limitations, financial limitations, but we have to proceed with that. Thank you.
Thank you, sir.
Thank you, sir. Sir, Gobinda sir, can I have a question to you?
Yeah, of course.
You mentioned during the presentation of the cases, during echo, one patient had diastolic MR. So what is the importance of diastolic MR finding in your echo for the students, basically? Diastolic MR.
MR always systolic during phase of cardiac cycle systolic, but one of the what are the causes? Sometimes in examination, somebody, our teacher or mentor, ask what are the causes of diastolic MR and complete heart block. What are the echo finding in complete heart block? So diastolic MR, one of them. When extreme bradycardia also causes diastolic MR.
Does it have any clinical importance?
There is no extra or clinical any importance. There is nothing. Just only academic
No, Gobinda.
purpose.
Actually, if diastolic MR is neglected for the long time in a patient, that is what's called the many of the time this is one of the criteria. There is the first degree AV blocker like this. The first degree AV block and extreme bradycardia one of the cause of the diastolic MR. In that case, if it is overlooked, there is the atrial dilatation and subsequently atrial fibrillation. This is one of the cause for the atrial fibrillation in the long
Yes,
run.
sir. This is one of the harbinger for future development of atrial fibrillation.
But my question to you, if you have a student who you ask that question and he could not answer it, what will be your judgment about that student?
No, sir, that is, this will not, but that is the, no impact on the results, sir, actually. This is.
Exactly. So these kind of rare things we ask, if somebody is getting, let's say, 90 out of 100, I want to see if he knows more than that, right? That's when you ask this kind of question, or you jump. Other part is that when you ask a question like this to average student, he will start sweating and then he will make mistake of other questions. So this question should be reserved for the best student. That let me see if he can get, he has got 90 now. Let me see if he's good enough to get 95. That's what we do.
Yes, sir. Sometimes this question makes the total examination difficult for the examinee. That's why I asked that question.
Of course, our job, I think one of the things that we need to, I am a product of that generation that I remember when I took my physiology exam, there is a professor, I forgot his name, he asked me about cholesterol metabolism and I told him that, and I got stuck at one place and he said, this is what it is. He answered for me and then I continued. Then I realized what he was doing to me was that he was trying to find out how much I know. He was not trying to find out how much I don't know. And I'm sure he asked the same question to other students. And if he had to correct me 3 times and he had to correct another one 10 times, he could tell the difference between two of us. So I think it's important that in exams, we change the pattern a little bit and make the students feel comfortable, ask them what they know, common things first. And that will be something, a good favor for the students.
Sir, I like to, pardon me, I like to introduce one of our student and a fellow colleague. He's very much interested in intervention in our department. Introduce yourself.
Assalamu alaikum, sir. I'm Dr. Wasim, sir. I'm doing regularly, sir, intervention in our cath lab and all primary PCI and also detectors, bifurcation lesions and all sorts of interventions, sir.
And other যারা আছে তাদের নামও বলো, ওটার নাম কি?
Also we have many of others. They are also growing. Dr. Johir and Dr. Tuhin and so many others.
Fantastic. No, this is good. This is fantastic
Please
news.
play for us.
Definitely.
Center is new and so many limitations are there, and we have to convince our patient, and we have to face many difficulties because of there is no cardiothoracic surgeon
Support.
backup. So we have to do with so many risks, but even though we are keeping up its journey, pray for us, sir.
Sure,
Okay, thank-
definitely. I'm very happy about Mymensingh.
Thank you, sir. Recently আসবেন নাকি স্যার?
এই বছর তো ছুটি ছিল, কিন্তু আমার লন্ডন আসতে হয়েছে একটু, আমার শাশুড়ি অপারেশন হয়েছে একটা, তো দেখি
ও।
নেক্সট ইয়ার বিগিনিং এর দিকে আসবো,
Sorry.
দেখা হবে তখন।
জি স্যার।
Thank you, sir. I'd like to request Professor Atahar Ali, sir, to summarize the session and wrap up the session. Professor Atahar Ali, sir.
So thanks everybody, and particularly thanks Gobinda for your excellent and very, very interesting cases for your presentation. Gobinda is a very popular teacher, organizer, coordinator, and sir, finally Gobinda is a very good singer, sir, also. He is a very popular among his students. So thank you very much, Gobinda, for your excellent
you, sir.
presentation today.
Thank
and
you,
hope
sir.
to
Pray
see you
for me.
again.
Pray for
শফিক
all
এর
of
সাথে
us.
তো অনেকদিন পরে দেখা, কি ব্যাপার? মাঝখানে তো শফিককে আছে এখনো নাকি মিটিং এ?
শফিক স্যার আছে না?
হ্যাঁ, অনেকদিন পরে। ভালো আছে, শরীর ভালো?